Good afternoon, everybody, and welcome to this afternoon's event. So this is the third taster session that we've been delivering over the course of last week and this week. And today's session is all about principles of high functioning organisations. So it's great to have you all here. I hope you're looking forward to the session. Just a few little housekeeping things before I hand over to our speaker today. So just to let everybody know that all of these sessions are being recorded and that those recordings will be available via the NHS Impact. Okay, can I just do a sense check with the audience, please? Can you hear me okay? If you can hear me in the audience, please, can you just pop a yes into the Q&A box for me, please? I've got a few yeses. That's great. Thank you so much, guys. We have had a few technical issues this morning, so I very much appreciate you bearing with us. Okay, so yes, I will just start again if that's okay. This is the third session of 3 that we're delivering. So today's session is around principles of high functioning organisations. We will be recording the session, so for anybody that hasn't been able to join today, or indeed if you want to go back and watch it again after the event, we will be making it available to people and we'll let you know how to do that in due course. If you've got any questions today, we will have an opportunity to answer your questions, so I would actively encourage everybody to pop those into the Q&A box. We'll have that monitored and we'll make sure that if we don't answer your question live on the session today, we will be making sure that we do a written follow-up of all the questions, and the transcription will be coming out and made available at the same time as the video. So it just remains for me now to welcome our speaker today, who is Chris Morrifrost, and Chris is the National Clinical Advisor to Hospitals within the National Integrated Urgent and Emergency Care Team, and he's going to take us through today's presentation. So over to you, Chris.
Hello there, everybody. So yes, it's Chris Morrifrost here, the National Clinical Advisor to Hospitals. It's a real pleasure to be here and to start this 2-year journey with you. So the session that I've been asked to do, if you go on to the next slide, is learning from the highest functioning organisations on UEC flow. So in a lot of the sessions that we've done already so far in this programme, I've been watching the chat, and you guys have been really engaging, which is great, and I hope you'll do that today. But you have been saying quite consistently, we understand the what that needs to be done in the majority, but actually what we'd really appreciate is, well, who's done this and how. And so some of this presentation today is going to be a little bit around giving you examples, but also doing some learning from a piece of work that we've done the last year, visiting different organisations. So next slide, please. So what exactly have we been up to over the last year? So I think it's probably a fair critique of NHS England historically, is that we're perceived sometimes as being the regulator that goes out into the community, looks at and focuses on really challenged practice or challenged organisations. But one of the things that we're trying to work really hard on is also another one of our roles, which is to recognise who's doing something really well, and then to go and have a look and talk and engage with them, and to harvest that good practice and then to share it with people like you. At the end of the day is that you probably don't have capacity to be able to go out and into different organisations, and also is that you may be not necessarily aware of everybody's data. And so at NHS England, that's exactly what we are in the privileged position of being able to do. And so over the last year or so, especially before the last winter, there was a lot of concerns around, well, what's the winter going to be like? What kind of resources and offers can we make to our most challenged parts of the NHS? But during those conversations, we also said, well, actually, is there something about going to visit and see who's flying under the radar, who generally isn't falling into challenged positions, who's doing something quietly in the background and just seems to consistently do well in a range of different things. And so at that time, we were focusing on, at the beginning, ambulance handover delays and who just didn't have them. And there were 16 sites that we visited there, and actually 16 systems, not just hospitals, because we found a lot of correlation around system working as opposed to what was just happening in a hospital environment. Then we did the same methodology again, and we visited 11 of the best organisations on admitted flow. And what I mean by that is everything behind on the emergency pathway, behind the emergency department. And now we're currently doing a third one, which is who's just very strong overall system wise on the UEC metrics. So how do we look at metrics? Contextually, it's good for you to know as we go through the themes of this presentation, is we ask a variety of very clever data analysts the exam question. And the exam question may be, who's just really good at ambulance handover delays? And then they break into separate groups using different methodology, different aggregations, lots of clever stuff to do with data, much cleverer than me, to work out, well, what is the answer to that question? And then we brought all of that data back, and then we checked it with system, regional and national leaders in UEC to say, does this feel right? And when it did, we engaged with the systems and said, is it possible we can come and visit you and talk to you about why you seem to be so good at this? And every visit was part objective. So we physically walked the patient pathway and looked in services with our own eyes. And it was a great collaborative effort with people from ESYST, regional colleagues, system colleagues, and us in the national team. But then also subjectively, is that what we found, and actually it's part of the themes, is that there's many people that are quite humble in these organisations that don't see that they're really good at something. They're always striving to do something better for tomorrow. But actually, once we gave them permission, you don't have to be humble. You factually seem to be really good at this. We subjectively then got under the skin and said, why do you think that is? And that is where this presentation was born from. And so for those of you who are interested, the last bullet on the screen there you'll see is all the kind of metrics that our data analysts looked at. Next slide. So what is this presentation going to be? What's it going to cover? And I hope that it's useful to you, and I hope that you re-watch it back on video again in the future, because it hopefully will help you along the next 2 years to start looking at actually what is going to be quite a lot of cultural elements as opposed to physical elements. But what we want to do is to share with you what are the most common factors that we found when we went into these circa 40 organisations. And also we're going to give you a couple of exemplars or a couple of examples of how they've done something and what they've done. But I think it's really important for the next 2 years to remember that no one hospital or any organisation or any system is perfect. There's lots of mitigation throughout the pathway that makes things better, but actually nobody in any of these organisations that we've visited have said we've finished or there's no work to do. They're all on a journey of trying to improve on yesterday. But the more, as it says in the last paragraph here, the more we try to ensure that everybody joins up, we all try to go in the same direction, the more we join up, the more successful things become. And ultimately, what are we in the business of? We're in the business of making sure that our patients are well looked after and the patient experience is as good as it could be. Next slide, go for it, Joe. Thank you. So what are the themes? These are them. This is what we found. You'll see that they're very ethereal statements, but we're going to break that down for you. So if we'll go on to the next slide, this is what you are going to see now on each slide. So this is an example of what am I looking at? So at the very top, you've got the title of the theme, the thing that we found. Then you've got a mini description of, well, what does that mean? What does that mean in practice? What's the definition? Underneath that, you've got 2 boxes where we've plucked a couple of examples from some of these organisations that just physically do really well. And then we thought, well, how can we be really helpful to you? And I hope it is helpful. In the bottom right-hand corner, you're starting on the journey of being a champion, and probably quite rightly, you're asking, well, what does that even mean? And so I'm going to offer one small answer to that question. And that means that you want to make a difference and that you're going to try and make a difference. And you've obviously got energy and enthusiasm, because either you got volunteered or you volunteered, but you physically turned up to this video or to this presentation. So there's something in you that wants to make a difference to the NHS around you and for your patients and for your colleagues. And so with that already said, it's the how. Well, what exactly am I going to do? I've got the passion, I've got the energy, I've got some commitment that I want to do something. But what are simple things that I could do that are going to influence my world the most as I go on this improvement journey? So in the blue box, the bottom right hand side, we've got a tip for you. One example, you don't have to do it, but hopefully it'll get your juices flowing. So next slide. So we're now going to go into all of these themes. So the first one is that these systems seem to have a shared vision and purpose. So I'm going to read out what it says there. Leaders understand each other's worlds and they spend time with each other. Leaders in these organisations and systems consistently spend meaningful time with their staff. So that's not just popping in and saying hello. Meaningful time means proper engagement with their staff. And the wider MDT is generally empowered to co-design how we want to work here, and they also perform peer-to-peer challenge and they work collaboratively. There's a collapsible hierarchy. Leaders are able to articulate a shared vision, so it doesn't matter what part of the system they work in, they're all talking in the same language, and it's all about quality. Safety, what's the right thing to do? And they go hunting for evidence that underpins that. So a couple of examples of that, Luton and Dunstable, they share live data and dashboards across their whole system. So not each provider just concentrates on its own data in a live fashion. Everybody gets to see everybody's information. And so what that means that across the entire system, all staff are looking at the same information, but most importantly, they understand it. And because they understand it, each provider within the system can react to when one part of it, the pathway becomes challenged. And something similar at Sherwood Forest, actually, they've created a RAG-rated version of that so that all partners can identify immediately where one part of the system has increased risk. But because they all understand what that means in practice, then mitigations are put in place to be able to react so that any one particular partner is looked after by the collective. So one thing as a tip that you could consider here is maybe once a month spend half a day in a service that's not your own or that you don't manage, so that you're stepping outside of your comfort zone and you can go and have a look at how something alongside you works. A long time ago when I was a general manager, I spent time in a GP practice because I needed to increase my knowledge of that area. I went and sat with a call handler in the ambulance service. I went into the community and went to and spent half a day with the community nurses. I believe that made me a better leader within the organisation I worked in. Next slide. Leadership. So we've talked about leadership a lot. But in these organisations, the executives are highly visible. They're described as empowering, proactive, but again, in that meaningful, engaging way. And they do so with a diverse range of staff at every single level across every single workforce. Executives are spoken about emotively and are described as being the living role models of our organisational values. And in their practice, they demonstrate compassionate leadership through consistent behaviours every single day. So not just one-offs, every single day. So Chesterfield and Chelsea and Westminster are two organisations where the executives choose to work shifts in different clinical areas every week. And the result of that is there's a greater connection between the leaders of the organisation and the coal face, and you can understand all the ripple effects that that would bring. Royal Berkshire, they have a director of the day inside their hospital. So the director of the day clears their diaries and they sit with the ops team and support the ops team and the rest of the organisation to deliver the operational functionality or flow of that day and work with system partners to do the same. So you can imagine that provides significant oversight, visibility. And then on an individual level, you can imagine their knowledge of the system, the working relationships, all improving. So a little tip here is invite a member of your executive, if you're not an executive, to work in your service once a month and to come and do half a shift or whatever it is, to come and actually see what the coal face tastes like. But equally, it's really important this, and I hope you don't mind me being a bit blunt, is that has to be a positive experience for them as much as it's got to be a positive experience for the service as well. So bear that in mind. Next slide, please. So data and information. So systems and providers proactively share their information. They understand each other's data, and then they use it to proactively manage risks across the whole pathway. Staff can easily access each other's data at a time that they need it, and systems use predictive methodologies and statistical process controls in their day-to-day operational management, but importantly, especially for the next 2 years, in their improvement journeys as well. So a couple of examples, Derby and Derbyshire, their system audits certain patient codes that are brought in by ambulance. And actually they as a system go, well, actually the majority of those codes shouldn't have been brought to the hospital. And so what they do is they gather their system leaders together to look at what went wrong in the process that it meant that the patient ended up in a hospital environment. And what do we need to do to tweak, to learn, to grow, to make sure next time that patient doesn't end up in hospital unnecessarily. And another example is Walsall. Their system performed the missed opportunity audits. That'll get picked up on, I'm sure, in the next few months, if you don't know what that is. But they essentially audited their activity. And as a product of that, as a system, it helped to define business cases that meant that they've got care coordination, and that's got better. They've bettered their or improved their streaming offer. They've reduced their ED attendances that aren't emergency in nature, and also that it helped them to get a business case successfully for a 24-hour urgent treatment centre on their hospital site. So a little tip in data and information is, if you can't see your system partners or your other service partners' information or data, why don't you reach out and say, would you mind sharing it? And also, would you talk me through it so I can understand what it means? Next slide. ABC, attitude, behaviour and culture. So this was a big thing across all of them. Organisations have proactively thought about influencing their culture and have really clear strategies around peer-to-peer accountability. So it isn't necessarily the top tier holding everybody to account. There's a culture of everybody holds each other to account. And leaders embody the language of we and us rather than you and them and I. How we work here has been collaboratively designed and upheld. So leaders have brought everybody together to say, well, what do we want to do here? What do we want to achieve? What have we got a zero tolerance for? And what are we going to absolutely all the time consistently deliver? And they have, on the back of that, a really high trust culture and a commitment to improve collaboratively. People trust each other. They trust each other that everybody's coming from the right place. So Sherwood, clinical leaders have collaboratively agreed to trust one another, and so and they role model this. So the medical directors, the deputy medical directors, they all role model this in all of their services, so that if somebody reaches out for support, for help, they want to transfer somebody, it's easy. And in some cases, they don't even expect you to reach out. Is that you can we trust that you know what you're doing, and if you need us, just make an electronic referral and we'll just see them straight away. You don't need to discuss it with us unless you want our advice. East Lancashire, the executive corridor is actually the trust's improvement corridor. So staff meet with executive every single morning to talk through whatever improvement journey that they're doing. And the staff say to the executive what they need the executive to do. What have they learned? What are the blockers? What do I need my executive or my directors to unpick for me? So you can imagine the beneficial ripple effects of that. Staff are empowered, they feel praised, problems are unblocked in a matter of hours, days, rather than perhaps just bringing things to a grinding halt. And many improvements as a result are sustainable and successful. So a little tip on this one is perhaps bring together a collection of clinicians to informally talk through this question. Do we think there's a culture of trust in our organisation? If there is, brilliant, how could we improve it? But if there isn't, what could help improve it? And whatever comes out of that discussion, why don't you take that to senior leaders within your organisation with a suggested, well, this is what we could do to maybe help that. Next slide. So care coordination. So this means care is joined up. Any healthcare practitioner in the system has equitable rights to access any service they think a patient needs. So perhaps for those of us who've worked in more challenged areas, sometimes the streamer can't get a patient into a service, but the GP can. And that just is a really good example of inequity between healthcare providers and practitioners. And in these organisations, there tends to be parity across the system. Services are geared up towards finding solutions collaboratively together. Again, it's based on that trust, but it's all about where does the patient need, and I trust your clinical judgment. So let's just coordinate together, collaborate together, and let's get the patient to the right place. In these organisations, it's less about does the patient fit my inclusion criteria. It's more about you've reached out to me and talked to me about a patient, so you must have thought I'm the right place. So let's go from there and see where we get to. So a good example, Warsaw, they've got a universal trusted assessor model that's been agreed throughout the entire system, which is basically what I've just described. But it does mean that patients go to the right place first time, which is often not the emergency department. Emergency departments are great for emergencies. They're not so great if everything else is going there. And at Tameside, they've got an integrated workforce across their community and acute providers, but they work together as on a single point of access, and they call that digital health. So basically, it's a blended workforce. Any HCP can ring up that number 24 hours a day to get advice, specifically from community healthcare providers, in order to stop unnecessary conveyancing. And since they started that about 5 years ago, they've seen a dramatic reduction in inappropriate conveyancing to their hospital environment. So a little tip for this one, gather a small group together to discuss, do our patients go to the right place first time? Do we think that? And if we've got evidence that they're not, what is it do we think that we need to put in place to encourage that to happen? And you can already see why this might get your juices flowing about some improvement kind of methodology or projects that you might want to work on. Next slide. Demand and capacity. So in these organisations, they've proactively looked at what services are needed. They've really got under the skin of, well, what type of activity are we having? And where we've perhaps relied on things like emergency departments to be that constant, always have the lights on, actually that's not future fit, and it's certainly not good for patients. So now they're really invested in really understanding what services are required, and then they're pushing forward in building and creating those. Organisations that really understand what new workforces and new services that are required seem to be more successful. And so what I mean by that is they seem to be ahead on the curve, or certainly quite committed to things like virtual wards, the expansion of different types of SDECs, single point of accesses, and then workforces about growing and developing their ACPs, AHPs and physician associates and other type of things to help them with workforce deficits. But essentially, successful organisations have right-sized for their demand. So Royal Berkshire, they've put a significant investment over the last few years in their ACP and physician associate growth. And what they've done is, rather than have those workforces working in silo in separate departments, they've created a developmental program. People can do it, or they don't have to do it, depends on what their preference is, but the majority of their staff, we were told, do choose to do this. They cycle throughout the system, so not just the hospital but out into the community. So you can see how that will join up and create tendrils, so a system is working collaboratively together. Another example, Sherwood, they've got a strong use of audit in understanding what's coming through to their front door, and they did that a few years ago, and so that's helped them to significantly expand their SDEC, frailty, specialities, receiving areas and urgent care offer, which has now put them in a position where they're routinely in the top 10 in the country on their 4-hour standard. So a little tip for you then, do a simple audit that looks at what part of the day's activity going into your hospital could have actually been managed elsewhere. And if you do have those services, ask yourself, well, why didn't they get to them? And if you don't have those services, does actually the system or the organisation understand that there is such a big need for that? Try to start listing why things didn't happen, because then you'll start listing opportunities to do improvements. Next slide. Processes. So organisations have brought the MDT, and what I mean by the MDT is literally every part of the workforce together to pose problems and encourage meaningful collaborative problem solving together. These organisations, we spoke to doctors, nurses, AHPs, managers, they're all on the same page because they're treated equally and they've got equity in terms of their voice and their opinion, but they genuinely are encouraged to listen to each other and work together to co-design solutions. So processes are based on what do we think is the right thing to do? And our primary concern is what's good for the patient. So in Salford, they've got strong clinical executive led, but collaboratively approached rollout of SAFER. So SAFER, again, if you don't know what that means, it'll get picked up in the admitted flow module, and also their board round processes. But they have consistently kept at that because they want to nail this and they know it's going to take them some time. But what it has done, early shoots, is improved ward functionality and actually discharges for them in a timely way. West Middlesex, the borough leaders within the system all came together to co-design what top 6 things are we going to really try and nail collaboratively over the coming years. And frailty was one of those. Let's join up our frailty offer. And so they're seeing an improved standardised frailty offer regardless of the entry point within the system. And that's not just NHS, that's local authority as well. And they're seeing some really good beneficial shoots from that. So as a tip for you, invite a group of clinicians and a senior/executive person within your organisation to help review a process that you all just feel just isn't working right now. And then brainstorm, well, what could a better version look like? And then just see what the gap is. How do we get from it's not working to the place of where it should be working, and just work out some steps. And there you might have just designed a Gantt or an improvement journey in rectifying that process and getting things better for patients. Next slide. Internal professional standards, we hear this a lot, don't we? But MDTs in these organisations are brought together to mutually agree, how do we want to work here? So often this is clinically led, so a very senior like medical director or director of nursing has backed this as a piece and champions it. But in essence, what it actually means is that peers collaboratively design what are the standards that we're going to work by in this organisation. And because they've collaboratively come up with that, they then collaboratively peer challenge each other. So they hold each other to account rather than this necessarily escalation tree of X speciality hasn't come to see this patient. And so I'm escalating that, is that they all just hold each other to account because they've all signed up because that's the way they want to work here. And again, it links back to that trust element. But culture, in essence, holds professional standards to account, as opposed to perhaps a dusty A4 sheet with a flowchart written on it. So examples of those are Milton Keynes. They've got a strong cultural adherence to an IPS, which was actually designed by all of the specialities and the emergency department together. And what they've seen is improved flow management and just basically things going quicker and better in the referral and advice portions of a patient's journey. In Newcastle, they all did a big talk, a big listening event, and they all came together to agree, well, how are we going to work here? What are the basic standard things that we think you should have no matter where you are inside of our organisation? But it was clinically led, co-designed, and leaders themselves, so the senior medics, the senior nurses, the senior managers, all role model this. So yes, we're creating this, but we're going to live this as well. And so therefore, the ripple effect of that is that all staff see their bosses, their leaders acting in a certain way. So it sets a cultural tone. So a little tip for this is find an internal professional standard inside your own service, which already exists, and go and ask a range of staff that are connected to that. Did they get the opportunity to design it, to co-design it? Were they asked whether they thought this was a good idea or their opinion? And if they say yes, brilliant, is there anything else they would now add? But if they say no, we weren't, well, if they were asked, what would it look like now? How would they change it? What would they do with that? And then that potentially you can see would lead on to perhaps a piece of work of redesigning and maybe trialing that redesign. Next slide. Adoptions of best practice. These organisations proactively go hunting for practice. So everybody is busy, everybody's challenged, everybody knows that. But these organisations try to prioritise releasing their staff to go looking and harvesting in other organisations. Staff are empowered to go hunting for best practice and good practice and alternative innovations, but also they go hunting for staff from other areas to come and join us. And when they do arrive, we leech them for anything that is different, that how they've done things differently in other organisations. So these organisations are actually at the forefront of innovation and redesign, and it's a real pleasure to go and visit them, because they are really trying to, how do we better today? How do we get better from yesterday? But importantly, and this is about capacity, staff are given time to go and visit and peer review. So in South Warwickshire, there's a strong emphasis on Consultant Connect. So basically people outside of a hospital environment being able to connect to a consultant with acute specialism inside the hospital, to be able to talk for anything within the 24-hour period to gain advice, rather than potentially convey a patient. And what they've seen is a significant reduction in unnecessary conveyance and an increase in general HCP confidence out in the community in managing patients. They did that through this adoption of best practice. And in Gateshead, they've worked with their urgent care and primary care partners to co-locate, to create a co-located UTC, which is managed collectively, collaboratively between them all. And they also offer a 24-hour virtual telephonic advisory service. So you can see why already that's going to benefit the emergency department in the hospital environment. So a tip: negotiate with your organisation that you want to go and visit another organisation that is doing something that you're not, and that you'd like to go and see it and ask them questions. And actually, I'd suggest when you go through your modules in some of the pieces that you're going to be concentrating on, there's real opportunity to get some collaborators in your sets and modules, and just see who's near you and see if you can go and visit them, invite them to go and visit you. Next slide. Not too far off the finish, I think. So this is really important, human factors, but it's also really difficult to knuckle. I think everybody on this call, listening, watching, will agree that human factors underpin practically everything that we do, because we are a people-run organisation. In these, and there's some really important lessons here, in these organisations, staff say they feel valued, and they are valued in a range of different meaningful ways. Their HROD and executive have deliberately designed an OD plan that now and in the future shows our staff that they're engaged with, that they're valued, and that they mean something to us. In these organisations, I mean, let's be pragmatic. Let's look at their results. The results are they've got in fact, one of them has the highest level of staff satisfaction results in the NHS survey than anybody else in England. So, you know, cause and effect, you could do an academic argument, but pragmatism would say there must be a relationship between them. And also, they do describe that they've got retention and recruitment issues, but as an objective observer, their retention and recruitment issues are not on the scale of perhaps more challenged organisations. So leaders, how do they do this? Leaders foster the values of treating each other well. They're highly aware, these leaders, they're executives, they can describe in quite good detail, in an expert way, the relationship between valuing and supporting your staff and focusing on human factors, and the correlation to staff producing really good patient care that gives patients really good outcomes and experience. So a couple of examples are there on screen. I'm cautious of the time, so you can look at that in your own time, pause on the video or look at the slides. But a tip for this is spend time meaningfully engaging with staff around you, and if you're a manager, below you, and ask them if they feel valued. And if they do, great. In what ways do they feel valued? But if they don't, ask them, if I had money, what would that look like for you to feel valued? But if I had no money, what things could we do as an organisation that would make you feel valued? And I think you might get some interesting answers there. Next slide. Patient experience probably should have got up at the beginning, but these are in no priority order. So these organizations proactively seek out patient experience and feedback. They engage with patients, they look at patient outcomes, and they really understand that patients are in essence our reason for being. They are our customers, and they should be the highest priority within what we do. In North Tees, they've got a 24-hour UCR in place through a single point of access, and they've created a blended MDT workforce that means that whatever a patient needs, no matter where they are within the community, on most of the time, they then get the right healthcare provider that they require. Now, they built that in conjunction with designing and getting feedback from patients themselves. In Royal Surrey, they've done a strong QI, quality improvement piece on more processes, which includes patients and families, and it actually has the standardised 4 questions. Again, in the admitted flow module, if you're going to do that, maybe ask about what are the 4 questions, but they've really run with that, and it's shown some incredible benefits with their length of stay and patient feedback. So a little tip, spend some time in a service directly and observe a patient journey. When's the last time you did that you created a window to actually see what it's like to experience your service through a patient's eyes? Next slide. Productivity. Organizations focus on bringing teams together to build on the how do we work here. They reduce unwarranted variation between individual teams. The classic thing is looking at the rota and saying who's working today. In these organizations, you don't need to look at the rota because it doesn't matter who's on, because we're going to deliver the service in the way that we all know it should be delivered, as opposed to who's on's version of today. So at Chelsea, well, again, I'm looking at time. You've got a couple of examples there, but perhaps a little tip in this, looking at productivity and variation, is bring a team together to conduct a grand round in your organisation, or if that doesn't quite fit in terms of wording, a peer-to-peer review, whatever that would look like, in order to encourage conversations about removing unhelpful variation. Next slide. Outcomes. So organizations focus on what's the right thing to do, even if it's difficult to do it. Where's the right place for the patient to go, and do we enable that? So staff are given capacity and empowered to do these innovations and understand, are we sending patients to the right place in the very first instant? 2 more examples there on screen for you. But another random tip, we talked about the missed opportunity audit, but there's other audits that you can do there. But why don't you randomly audit your activity into your emergency department of a given day and have a proper look to see, are we really getting people to the right place? Next slide. So those were the themes. That's the overarching thing. And I'm about to wind down, Lisa, so get yourself ready. But in conclusion, you can see there's a lot to take in there, far too much for you to take in right now. And it'd be really interesting to see what kind of the chat and if there are any questions. But in conclusion, actually, a lot of the elements of successful organizations were cultural or behavioral in nature, as opposed to necessarily the provision of estate services and workforces. Now, I'm not saying that those things aren't important, because they are, but actually perhaps there is a huge bundle of opportunity in focusing on behaviours and culture that will give us a lot more free bang for our buck. But the most prevalent things are executive leadership and oversight, strong clinical engagement, especially with ops, empowered staff giving capacity to make changes, lots of joined up services working together, but specifically making sure that there is this collaboration of trust, engagement and communication. All soft stuff, but if you work on it, it's obvious the results are good. Thank you very much. Lisa, I am over to you.
Brilliant. Thank you, Chris. That was a really, really enjoyable session. And just speaking from my own personal experience, I always find it very useful when I'm embarking on anything to hear about what other places have done, and be able to connect up with them to find out what not to do as much as what to do. So I think that's been really helpful. We do have a few questions, so I will take you through those. So first couple of questions are just around the visits themselves. So we've got the first one: were the visits anonymous? And the comment being made that if people are aware of these visits, particularly when it's at NHS England, you can basically pull the good out of the bag. So any comments on that, Chris?
So just in case I'm staring at a screen and people thinking that I'm just staring into the ether, we've been told that we only speak when there's a red box around our face. So that's up now, so hopefully you can hear me. So they were anonymous, but let's be a little bit pragmatic here. At the end of the day, the data was anonymous in that we factually went hunting through quite a good data methodology of, well, who's just doing well performance-wise here? But, you know, speaking amongst friends is that the data says one thing, but actually you learn a lot from your own eyes. And this wasn't going on visits and sitting in a room and being told. This was getting under the skin. There were quite big things. We spent an entire day walking through entire patient journeys, speaking with patients, a whole range of staff at all sorts of levels. And I think everybody on this call knows that, and we didn't have chaperones necessarily either. So I think everybody on this call knows that if staff are really encouraged to really talk things through, and if there is an issue, they generally do say it. And they did have challenges, they did have issues, but we genuinely felt like our objective eyes met what the data was telling us, and we really wanted to understand why, and we believed them.
Thank you, Chris. So another question just around the visits, really, the comment about it feels like it's very hospital, very acute focused. Just in terms of overarching principles, would you say the same applies to organisations outside of hospital? Or is there anything that's been done across NHSE that has picked up some of those principles that are more for outside rather than within the acute sector?
So there I am smiling at Lisa, we can see each other. So short answer is I'm the National Clinical Advisor to hospitals. So the work that I will do is always going to start at hospitals. But actually, I hope what's come across here is it's about systems working together. So I think that's important to recognise that hospitals can be sometimes the barometer of how successful things are working at a wider system level. But I won't apologise for the fact that I work in the hospitals team, so the work started in the hospital environment. Having said that, though, so Lisa and I have done work with some systems. We've been invited to go and do some collaborative improvement, thinking about what kind of improvements do they want to do. And this presentation and presentations like this I've been doing for the last year. And to system partners, it's almost a question straight back to you, whoever's asked that, is that system partners have told us who don't work in hospitals, do you know what? You could lift all of these and stick them in our world because they're just as relevant as and important than just the hospital piece. And so a good example of that is we didn't talk necessarily in that your ED needs to function this way, or you need to have an SDEC, or you need to have a virtual ward. Actually, the majority of these slides around the cultural and behavioural aspects, and that I think steps beyond which of the providers you sit in.
Okay, that's great. Thank you, Chris. I'm going to put two questions to you now, and that's just to give Joe a little hand so he's not bouncing between you and I. The first one, I think, is just quite a generic one. If people want to be put in contact with the areas that you've described today, just to go out and reach out to them and have a conversation, are we able to help delegates out with how they make those connections? So that's the first one. And then the second one is specifically around one of the examples. It was the Tameside one. What does single point of access actually mean? Does this include all of community healthcare, i.e. district nurses, physio, etc., as well as social care referrals, voluntary sector, and therefore does it include lots of organisations in one physical space to manage this? So just a little quick reminder, can we put people in contact? And then that one specifically around the SPC at Tameside, please, Chris.
I'm really glad you did the recap at the end. I was like, crikey, there's more than one question in here. Right, so can we put people into contact? Short answer is, of course we can. But if 800 people want to talk to the Chief Operating Officer at Walsall, I don't think he's going to be particularly happy with us. So I think it's something about being coordinated in this. So yes, by all means, reach out to us, reach out to any of us, stick it in the chat, or use the email addresses that you've got if you've got a burning desire to get in contact with these people. But equally, you've signed up to, or your systems have signed up to modules. So right very early on, why don't you go to your module and say, actually, I'd really like to hear from Mimsville Hospital because I heard they were doing something really good on Y. Or even if we didn't cover that, because these were only just a small cluster of examples, ask your modules, because they will be planning this anyway, ask your module facilitators, are you going to bring some people to come and talk to us, perhaps in any of our sets or whatever, that have done this and done it successfully, so we can just pick their brains. That might be a nicer way to do it than perhaps sending 700 people in the direction. And then in terms of Tameside, if anybody's on from Tameside, I'm very sorry if I get this description wrong, but this was my observation of Tameside. So around about 5 years ago, they set up this thing called digital health. As I said, it's lots and lots of different workforces from different parts, yes, inclusive of some of those roles that you read out in the question, but from the acute world, from the community world, but brought together into a hub. And in essence, one of the things that they did is they gave all of their care homes, nursing homes, residential homes an iPad. I believe that other tablets are available other than iPads, but they gave them all an iPad. And they basically said, if it's an emergency, cardiac arrest, something horrific, trauma, by all means ring 999. But if you don't think it meets that bar, connect with us first. And what they do then is that all of these healthcare, residential care, etc., services get to then have a live virtual 24-hour conversation with somebody, and they're matched to the person that is most appropriate for their need. And so they give live advice, often out of hours, when often in these places there's the most junior members of staff on. But then they connect services the following morning, etc., so that services go to the patient. And what they say they have found through that is that they've seen a steady reduction in inappropriate conveyancing from care homes into the hospital environment and through the ambulance service. But they've also seen through their I'm going to say this acronym wrong. The people who link with the practices. Is it PCNs? I should know that, but I don't. It's all about being honest. But their links with these care homes, they've said that the confidence of staff in care homes has steadily been increasing because of the skill set of the staff that they get to speak to in that virtual way. So that's just one example, and that's just bespoke for what worked at Tameside. But hopefully, it gives you a flavour of the kind of thing that they've co-designed and created. Thanks, Lisa.
Thank you for that, Chris, and well remembered. Me throwing 2 questions at you there. That was a little test and you passed. Well done. Okay, next couple of questions again, but I'll combine them into one. Just some comments around data, and that historically we've sort of worked within our organisational boundaries, and we've been a bit confined by security protocols, Caldecott and all of that kind of thing. So any hints and tips on how now we're working more at system level and working in a more integrated way, how do delegates and colleagues on the call today get over some of those historical barriers so that we can just get on and do the improvement work that we need to do?
No, absolutely. Good question. So I don't necessarily think I've got the absolute answer for that. And I hope that people watching will be sensitive to that, because it's bespoke. It depends. It also depends on where historically you've been and who you're talking to. But fundamentally, Lisa's nailed the answer already, I think, is that systems now are working together in order to make sure that we consistently provide the right kind of care. The most successful organisations and systems in the country are sharing their information in data. So we, NHS England, in ESIST, at a national level and at a regional level, are aware of systems that are doing that. So if there are services or organisations or systems that are finding that difficult, I would suggest try and work it out as a system or between services. But if you're really hitting a brick wall, invite in your regional colleagues, invite in national colleagues, ideally regional first, of course, to see if we can't broker and help. Because something at NHS England we can do, and it will be bespoke to the ask, is say, well, if the ambulance service don't feel that comfortable in sharing their information, we can go, but here is one ambulance service that has done that with all of their systems. So what is it that they've done that might make your ambulance service feel more comfortable? And so there's that mutual learning. I think that is one of the roles of NHS England and the regional teams, is to learn how other people have done things successfully. I hope that answers the question, Lisa.
Yeah, well, it certainly does for me, Chris. So hopefully it does for the people that pose the questions as well. That's really helpful. Thank you. So an interesting one now, and I do want to pose this question because it's a similar theme to questions that have come up in the other two taster sessions as well. So I think it's good that we've got this golden thread here, and it's just around the fact that traditionally there's quite a hierarchical structure in management within the NHS. And you may experience that through those hierarchies, sometimes there are agendas and there's politics to manoeuvre around. So the question here is, how are NHS England going to support some of the cultural changes required to get around that? And I'm sort of going to add my own bit to that, really. I think it's more about what can we do to support people to develop the skills so that they're able to manage it themselves and not necessarily need NHS England to come in and manage it for them. So I think where we do have some of those traditional boundaries, hierarchical structures, politics, and actually people just want to get on and do and make a difference and make things better, what hints and tips and advice and guidance can we give them, Chris, to help them on this journey?
So I'm kind of wishing now that I just kept my presentation going longer, because these questions are now getting more and more difficult. I'm earning my dosh here, aren't I? Right. So I think it's really important to say that anything I say, I don't speak on behalf of NHS England. I speak on behalf of Chris. So I think that's a hopeful context there. I've not done as much improvement work as the people like Lisa and other outstanding ESIS colleagues and in the Improvement Directorate, who are experts at facilitating improvement, because improvement's not necessarily about what is it you want to change. It's very much more about how, and I think that's where this question is hinting. But in my experience is you can't go wrong in spending a good chunk of time understanding who your stakeholders are and bringing them together and really understanding with where they're at, what motivates them, what turns them off, and what turns them on, if you pardon the phrase, is that this is very much about, we're only going to be successful if we work together on this. And so I think that, you know, there's probably two parts to the answer to this question. The first part is what I'm saying now, is that the quickest way to turn people off if they don't feel like that you're engaging them or working with them. And so that's really getting under the I think you're doing this in the improvement type module structure, is the quickest way to turn people off is to go to them and say, we've got to do this, and so therefore we're going to do it. The best thing to do is actually pitch a vision. I think the was it Martin Luther King, the thing about I have a dream, is really powerful, is that let's work together about what our dream is, what is it we want to do, what do we want to achieve. And that, in my experience, wins loads of people round to which direction are we walking in, if it's done really well. And I think that you've got lots of support for you in the modules and through colleagues in the Improvement Directorate, where you can really pick their brains, regardless of what the bespoke kind of blocker is for you, because I don't think there is a universal answer. But I'm going to try and tackle the second part of that question, which I think is kind of what it's asking, is that sometimes you've just got to manage upwards. Not everybody in every leadership position is necessarily highly skilled all the time at being a great leader. I'd like to think everybody in the NHS, their value is they want to do things right for patients, but we all know it can be chaotic, it can be highly emotional, it can be incredibly difficult, and the in trays are never empty, and you're always juggling and fighting fires. And so sometimes there's days, weeks, months, we're just not the best versions of ourselves. And managing upwards is a skill for everybody, regardless of the role. And so it's just the best tip I can give in managing upwards is step into their shoes and imagine what it's like to be them right now. See if you can try and find a hook or something that will really ding a bell in their mind. And that's what I mentioned about stakeholders and understanding what makes them tick, and latch on to something that's important to them and start brokering a relationship. But ultimately, if it is hierarchical and you're told no, then you're told no. And you can either choose to circumnavigate that in some way, but that's probably a destiny for something bad. That's not going to be a great thing to do. The best thing to do is just to keep on trying, engaging. And then the last thing I'll say, and then I'll shut up, is that in my experience is that when you are faced with a blocker above or a blocker around you, where for whatever reason they're not with you, and you've tried everything in your armory, your own personal armory, on how to crack the nut, is that I find it really helpful to look elsewhere to what resource can I tap into, what person can I tap into that can either give me advice, or we can do a two-pronged attack kind of thing in trying to work on this together. The key word here, I think, is collaboration, not only with everybody to stop that from happening, but also is that if you can't get beyond the wall, collaborate with your clan, with your tribe, with your pack to see if you can't do it together en masse. Don't know that's a particularly good answer, but it's my honest one.
No, it was a fabulous answer, Chris, and I wouldn't have expected any otherwise. It also gives a nice segue in as well, just to let you know now that's your last question, so you can breathe. So it does give a nice segue in, because I think taking that last question and actually taking the advice and guidance that Chris has offered there, for those of you that have joined us today that are UEC champions and are participating in the core learning events at the moment, next week, core learning event 2 is all about leadership and delivery of your programme, and some of what Chris has just described there will be gone into in a bit more detail in the core learning event next week. So you would almost think Chris and I had rehearsed that, and I promise you that we hadn't, because we didn't know that question was coming up. So huge thank you, Chris. I think that's been a great session. It's certainly from the comments and in the chat there, people have taken some real positives away from it, so thank you. Just a reminder to people that the video recording will be available, and you will be informed of where and how you can access the video in due course. There will also be access to the transcription in case there is anybody who has accessibility needs. Transcription will be available also. So that is the final taster session that we're offering as part of the Universal Support Offer programme. However, we have got the core learning event sessions that are currently ongoing. So core learning event 1 is well and truly underway this week, which is around prepping for your journey. Next week, it's around the leadership and the delivery of your programme. Week 3 is around measuring the impact of your programme of work. And then week 4 is just some tools and techniques. So we look forward to seeing many of you at those sessions. Thank you so much for joining us today, and we will see you again very soon. Take care and goodbye.